is a pain specialist who is basically an anesthetist, but she has done her fellowship in pain medicine from Sanjay Gandhi Postgraduate Institute, Lucknow. And she has worked in palliative care also for more than 2 years. And right now she is working as a consultant in pain medicine at Kim's Hospital, Trivandrum. Um, and she has done her um, certificate course in pain and palliative medicine too. Her areas of interest are interventional pain management and regenerative medicine, managing neuropathic pain, cancer pain, and palliative care. So, welcome, Vineetha, and yeah.
So Vineetha is trying to join. I think she's having some network issues right now. She'll be joining us in 5 minutes, I think.
Okay. So I think we can start the session. So I would, if you have any doubts regarding the previous or yeah, till Vinita joins, we can discuss about the previous modules you have gone through, and you can ask if you have any doubts. Anybody?
Sir, you are muted, sir.
Yeah. So if you do not have any questions, I
Sir,
think
there is one in
I
the
would
chat,
ask.
sir. There is one comment in the chat from Dr. Krishna Banerjee. The modules are very lengthy and repeatedly we need to read the same history, which is time taking.
Yeah, basically, all these modules goes through one or two patients. So the patient story will be continued throughout the um, um, pain modules. So that's for continuation. Otherwise, if it is on just theory only, then you will feel bored. So it is through the patient each module is going. Uh, so it is not necessary that you need to go through all the patient stories. And if you are familiar with patient stories, you can definitely go through the next step. But in each module, the patient story will be advanced. So I think it would be important to read each patient story. And usually it will take about 1 to 1.5 hours for completing each module. Um, and sometimes some people complete in 1 hour also. So it all depends on how you are allotting your time and your experience with the medications, pain management, etc. That would affect how much time you need to spend in each module.
Sir, there is
Okay,
one
where
more
do we get?
question.
Yeah, I saw that. Where do we get the information on the availability of opioids in India and formulation? So there is a um, video which you need to watch in this LMS regarding opioid availability, specifically on opioid availability. We can discuss more about that when the session comes. But it's already included in our module as a video. And uh, uh, a few things about availability and formulations are morphine capsule or tablet. It is available to you if you have a RMI. RMI means it is a recognized medical institution. So, a recognized medical for a hospital or a clinic to become RMI, there are few criteria that you need to be fulfilled. One is that there should be safe locking capacity for keeping the essential narcotic drugs, which include. So please remember essential narcotic drugs, which includes morphine, codeine, methadone, fentanyl, oxycodone, and hydrocodone. In India, oxycodone and hydrocodone are not available, but we have all the other four opioids. These six are known as essential narcotic drugs, and this essential narcotic drugs are it is the central government will be giving us which all are the essential narcotic drugs. So these are the six essential narcotic drugs as per the NDPS amended Act in 2014. So NDPS Act is Narcotic Drugs and Psychotropic Substances Act, which governs the stocking and dispensing of opioids in India. So if you have RMI status, and this status need to be applied to the state drug controller. So you should have a safe dosing capacity, and there should be a doctor who has at least 10 days of experience in pain management, and there should be enough space for the patient to come and sit in your clinic or your hospital. So if you fulfill this criteria, your hospital can apply for RMI status, and the drug controller will be providing you with RMI status. Once that status is available, then you can get morphine from the dealers.
So Dr. Vineetha has joined us now.
Okay. Anybody else want to ask? So do you have any doubts regarding morphine, fentanyl, or methadone, which was covered in these modules?
Am I audible, sir?
Yes, yes.
Okay. Good evening, everyone. Sorry for the delay in joining. Actually, due to the rains here, my laptop was not getting connected to the internet. So I think we can start by sir has already started, I guess. Doubt clearing.
Yeah. We just started, and it's waiting for them to come with the more questions. Yeah. So there is another question. After completing this online course, can we apply for RMI status, or we have to do 10 days offline training for a friend? So just want to ask you, from which state are you? Dr. Isha, where are you from? Okay. So basically, if you complete this course, you can apply for RMI status. And the drug controller of Kerala has approved this online course for applying for RMA status. And there are many other states who has given permission for applying RMA status with this online course. So you can apply with this certificate.
I think we can start with our discussion on morphine, sir. What do you think?
Yeah,
Any
yeah.
doubts regarding morphine you can ask, or we will, I will say case scenario and we can go accordingly. What do you want? Somebody can unmute and say that whether you want to ask doubts, we'll clear it that way, or we will go with, we'll start a case discussion, and along with the case scenario I will present, and along with the case scenario we'll discuss your doubts. So can you please say how you want it?
Vineetha, I think it would be better if you can present
Yes.
and let's get input from them.
Is my screen audible, sir? Sorry, is visible, sir?
Yes, yes, it's visible. Yeah, visible.
So I hope I'm visible as well as audible. So
Vineetha, you
yeah,
are audible, but
yes,
not very loud.
loud. Okay, let me
I
increase
said
the
because of
volume.
your throat problem or
Yes, both.
okay.
Just a minute, sir. I'll increase the volume as well.
Yeah,
Meanwhile, you can go through this case history. And
yeah.
I think I have been told this is a discussion session. So kindly come forward. Whether it is right or wrong, it's not at all a problem, because I don't know how many of you are already practicing palliative care. Many may be very new to the this topic. So it's okay whether you are wrong or right, but unless you communicate, it will be difficult to go ahead, because this is a discussion session, not a talk or a webinar. Okay, so let me increase my volume. Meanwhile, you just go through this case. I have given only the bare details because our discussion will be on opioids, not on anything else regarding to the cancer management. So kindly go through the case and think what is your next step. And instead of putting in the chat, you can put in the chat also, but I'll appreciate if you unmute and say whatever you think. Okay, that will make the session more interesting. Okay, so this is a 60-year-old male, abdominal pain for 2 months, associated with nausea and vomiting. So on evaluation, he was diagnosed with the carcinoma pancreas, head of the pancreas, and he is recently diagnosed just like 2-3 days back, and he is about to start treatment. So meanwhile, during the evaluation process itself, you have seen that patient, and the patient complains of severe aching epigastric pain that often radiates to the back, and his pain score is 8 out of 10. So you have started the patient on paracetamol, tramadol. There is inadequate relief, and he took even NSAIDs for 1 week during that evaluation process when it was going on. At that time, he had some relief. But after that, when NSAIDs were stopped and he was put on tramadol, I think he was put on 100 mg. We titrated up to 50 milligrams 6th hourly and then titrated up to 100 milligram 8th hourly. The patient was not getting adequate. relief. And so he's about to start the treatment for the same, whether they are planning to keep a tumor board to decide whether to go ahead with resection or first chemo and then go for resection. And as per the PET scan, no metastasis as of now. It's a locally advanced disease, but no metastasis. And he doesn't have any comorbidities and blood investigations were normal. So how will you proceed with respect to pain management?
So Dr. Reddy, you can unmute and speak.
So, like, I just wanted to respond. Maybe, like, we will start with the comprehensive pain assessment again
Yes.
and ORT, like, assessing for the risk tool,
Mhm.
and then decide for morphine and starting with a lower dose of morphine.
Pardon, you told first comprehensive pain assessment and then
The risk assessment tool,
risk assessment.
substance abuse risk
Vineetha,
assessment tool,
it is
ORT.
talking about opioid risk assessment
Yes,
tool.
yes, I understood. Okay. And then, so my question here is, do you think that you can start morphine when this patient is just diagnosed and not even started treatment? So, what is is it the right time to start morphine? Do you think?
Yes, because the pain is very severe, and also the paracetamol and tramadol is not working for the patient.
So that is exactly the first point to take home, that morphine can be started at any stage of the disease, irrespective of the stage of the disease or treatment. If the pain is severe, the morphine can be started. Okay. Now, second question is, how will you start morphine? Sorry, I'll go to the next page. Because there is a common myth that morphine is something which is reserved for the beginners in this group, for the end stage disease, or when everything else has failed. So that is absolutely wrong. Okay, now how will you start morphine?
I can see some response in the chat. Dr. Das says start with tab morphine 5 milligram 4 hourly and rescue dose along with the laxatives.
Okay, so I hope everyone agrees with that.
No, reduce the then start 10 milligram 4 hours.
Okay, so I hope everyone agrees with that. It is 5 milligram 4th hourly. Usually that is how we start morphine, and definitely we will add a laxative, and we'll come to that adverse effect management later on. So 5 milligram 4th hourly you have started. So how will you titrate it? When will you review the patient and how will you titrate it? Please somebody come up with answers. No problem if you are wrong, but you can just unmute and say. When will you review the patient? When will you ask? It can be a telephonic review, but when will you ask for a review?
After 5 days.
After 3 days. Okay, so for morphine,
So 1 week.
No, actually, morphine takes just 24 to 36 hours for the steady state plasma levels to attain. So you can review the patient in 24 hours or 24 to 36 hours, 1 to 2 days. It's not like 1 week. Okay. Next 1 to 2 days, you can review the patient. So what will you ask to the patient during review? How is your pain? Is it well controlled on morphine? Is he, how much percentage, like is he getting 100% pain relief, 70% pain relief? How much pain relief he is getting with this 5 milligram? How much duration? Is he getting 4 hours? And third, how many rescue doses he is taking? These 3 questions per day. How many rescue doses he had to take in the last 1 or 2 days? So because you will be reviewing in 1 or 2 days, 24 to 36 hours. So these 3 questions you'll ask the patient. So after that, how will you titrate? Suppose the patient says that I'm having more than 70% relief, but I'm getting only 3 hours, or I need to take more than I'm taking more than 2 rescue doses per day. So how will you titrate? If somebody has written total morphine dose by 24 hours, that is, if the patient is taking less than 2 rescue doses, 5 mg 4th hourly plus less than 2 rescue doses, then you can calculate the total morphine dose and then divide it by 24, not 24 hours, divided by 6. Because our final administration is 4th hourly. So the total daily requirement of morphine, that is 5 milligram 4th hourly, means 5 into 6, 30 milligram the patient is taking. Plus the patient is taking 2 rescue doses. That means 30 plus 10, 40. That 40 you have to divide it by 6, and that much you will give every 4th hourly. If the patient is taking only, either if the patient is comfortable with this 4th hourly dose, or if the patient is taking less than 2 PRN doses, this is how you calculate this is how you will proceed. But I am asking, what if the patient is taking more than 2 rescue doses, or if he is simply saying that he may not be taking rescue, but my pain relief is not adequate. How much will you increase? And how frequently you will titrate?
We can increase to 10 milligram 4 hourly with rescue doses. After 2 days, we will see the pain relief of the patient. If the VAS score comes down below 4 by 10 or 5 by 10, we can continue that dose. Either that, or if the pain is not relieved by that dose, we can increase to 15 milligram 4 hourly.
Okay, that is correct. And maybe in frail patients, or sometimes we can just increase by 50%. That is from 5 milligram directly from straightly going to 10 milligram. We can try 7.5 milligram 4th hourly and then go to 10 milligram. So depending on the pain response and depending on the patient's other conditions and status, frailty and everything, you can decide. So anyways, it is almost 50% increase every 2 days. So like this, every 2 days, you have to review the patient and titrate up the dose of morphine. And so initially for the first 1 week, you can review the patient every 2 days. Telephonic review is enough and titrate the morphine dose accordingly. So by that time, usually the pain will be, you might have stabilized the dose of morphine. So my question is, how much you will titrate? Till what dose you will titrate up morphine?
Or what is the endpoint of titration?
Correct.
Dr. Neenakshi says till sedation. Anybody else? Or adequate pain control. Okay.
Yeah, that is correct.
That's
But my
from
question
Dr.
was, okay, yeah, we will titrate till the patient gets adequate pain control, or if he gets sedated or the side effects come first, then we have to stop and think of other alternatives. But my question was actually, what dose? Yeah, somebody has written the correct answer. There's what Dr. Manglik Das has written the correct answer. There is no upper limit for morphine. So you don't have to be worried if your patient is getting some, what you have to see is whether the patient is getting a linear response. You have increased from 5 to 10. His pain was settling, it was decreasing, and you might manage the pain at 10 milligram for some time, for say 2 weeks or 1 month. But again, as the disease is progressing, or maybe initially itself, if it's a very rapidly progressing tumor, you have increased to 10 milligram, the patient's pain is better, but then it is not adequately controlled. No side effects. No side effects means no uncontrolled side effects like sedation or anything. So you can increase the dose further. So you don't have to be worried. I'm already at 20 milligram of morphine 4th hourly. The patient is, the pain is better with 20 milligram than with 15 milligram. But the patient is not getting a satisfactory pain control. You don't have to be worried about it. We can increase. There is no ceiling effect for analgesic action of morphine. We can increase the dose of morphine as needed. No upper limit. You don't have to be worried that it's already 10 milligram, 15 milligram, 20 milligram. At any course of titration, you don't have to be worried about that. provided the patient is tolerating the drug well. No, my slide is, the next question is not coming. Give me a minute. Any other doubts you can ask? Yes. The tablet or oral morphine solution, see, generally we start with tablet only. Oral morphine solution, if the patient is unable to swallow the tablets, then we can go for oral morphine, like in CA, tongue, buccal mucosa, or larynx, pharynx, any condition which the patient is unable to swallow. Okay, the next question is, now we are starting the morphine. So how will you educate the patient and how will you manage the adverse effects? What are the common, because when you are starting the morphine, you should definitely be telling the patient what they have to expect. What are the adverse effects that they can expect and how will you manage it? So somebody has told in the beginning itself that we have to write a laxative. So the hand that writes a opioid should write a laxative. So that is the first adverse effect, constipation. And we have to write a laxative. But what laxative you will write? Because we know there are different kinds of laxative. There are bulk forming laxative, smoothness are there, and then stimulant laxatives are there. So which laxative you will write?
Stimulant laxative and
Yes, very good. And anything else? Stimulant laxative and any other option? Yes, lactulose somebody has written. That is, we can give osmotic agents or smoothness. That is, that can be given. Talcolax is a stimulant laxative. So cremafine, so that is liquid paraffin, lactulose can be given. What should be avoided?
bulk
What kind
forming
of,
laxative.
yeah, correct.
Bulk
Bulk
forming
forming
laxative
laxative should
isabgol.
be avoided. So, and how long this constipation will last? Is it a self-limiting complication? So, sorry, I can't say complication, adverse effect. You tell the patient you have to take for one
No.
week, 2 week.
It does not self-limit, ma'am.
Yeah. Sometimes we can say this is one side effect which is not self-limiting. Many other adverse effects are self-limiting. So what are the adverse effects that are self-limiting? What can the patient expect in the first week of starting, the initial 3 to 5 days?
Sedation, nausea, and vomiting.
Correct. Sedation, nausea, vomiting. So what will you tell the patient regarding that? For sedation and for nausea, vomiting, what will you tell the patient? What will you give the patient?
Metoclopramide for nausea and vomiting. We can add for sedation.
For sedation, we just have to reassure the patient. So initially, there will be a little bit of a sedation, but sedation is different from drowsiness. Is it different? Is it
Yes,
different?
it is. Due to morphine tablet, we have to tell the patient you will feel drowsy, not sedated. Actually, I think.
Actually, a little bit of what I usually tell the patient is, it is very common when you start morphine, after taking the tablet within 30 minutes, usually by 30 to 45 minutes, the patient's pain will come down and patient will go to sleep. Okay, and he may wake up usually after 1 or 2 hours. This is very common, right? So we can say a little bit of sedation will be there. But drowsiness is, suppose after waking up from the sleep, or if you try to wake up the patient from sleep, then also the patient will not maintain a wakeful state. He will go on to sleep again. So that is what, when I tell the patient is drowsy, he will not be able to maintain a wakeful state. So usually a little bit of that sleeping or sedation will be there in the first week, 3 to 5 days initially, or maybe for 1 week. And for that, just reassurance is enough that it will go away on its own. But if the patient is excessively drowsy, then what the patient has to do or what the caregiver has to do? is reduce the dose. More importantly, skip the next dose. If the patient is continuing to be drowsy, that is after the first dose, the patient has gone for a sleep, he has waken up from that, but he's still he's not able to maintain that wakeful state. He's still kind of drowsy. So if the caregiver gives the next dose again, that may go on to that will become problematic. So you have to skip the next dose, inform your doctor. That is, we will have to, as we have got multiple opinion in the chat box, we have to reduce the dose. Okay, so skip the next dose, and then after that, once the patient becomes awake again, once that drowsiness is completely resolved, we can start morphine again, but in a reduced dose. Do you agree with me? I think we need a little more energy and sound in this discussion. Right, Sunil sir?
I can see there is one more. Dr. Reddy has written, avoid driving.
Yes, yes, yes.
Everybody, please wake up.
We are talking about morphine. I think everyone has already, they are sedated, I feel. Right, okay. So,
Madam, actually, if we skip one dose, so we can reduce the dose from beginning before titration. If we titrate a dose on 10 mg morphine 4 hourly, so we can give the patient 7.5 mg dose 4 hourly. If we skip
yes.
a dose, if we skip a dose, will it be problematic to reduce the pain? Because
No.
the peak effect will be peak effect of the morphine is like 60 minutes, 1 hour, I think.
So what I meant is, in skipping the doses, don't give morphine if the patient is already in a drowsy state. After the first dose of morphine, or suppose you have increased the morphine recently, the pain was stable on 10 milligram, the worsened recently, and you have increased to 15 milligram, now or 20 milligram. So after giving the first 20 milligram of dose, after 4 hours, if the patient is continuing to be drowsy, then I will wait till he is completely awake, responding, and the drowsiness has settled, and he has started complaining of pain, and then I will restart morphine in a lower dose. I feel it is more problematic to give when the patient is still drowsy. The next dose when the patient is still drowsy. That is what I said. I didn't mean that you have to skip and wait for another 4 hours. You have to skip the next dose and wait for the patient to be awake and responding, and the drowsiness has completely gone, and the patient now will start complaining of pain as well. They start complaining of pain. That's what I feel. And that's how I do also. Okay. So that's about sedation. If any other questions, you can put in the chat box. About nausea, vomiting, we have already discussed. We'll give metoclopramide and any other antiemetics that we can give for morphine-induced nausea, vomiting.
ICPM and ondansetron.
Ondansetron, and we can give haloperidol. Yeah, correct. Haloperidol as well. Haloperidol is very effective in managing this opioid-induced nausea, vomiting. What are the other adverse effects? So we talked about nausea, vomiting, constipation. Next. Pruritus. Is it possible? So, okay. And what is the drug of choice for opioid-induced pruritus? So, you can actively discuss, because we have to go a little more into methanol.
Corticosteroids in pruritus.
Pardon?
Tablet, cetirizine tablet.
The voice is not clear. Which drug?
Cetirizine, antihistamine.
Antihistamines. No, actually, Yes, but what is the drug of choice in opioid-induced pruritus? One answer. What is the drug of choice? Or generally considered as drug of choice? Pardon? Actually, no, I'm asking about pruritus. No, sorry, not pruritus. Yeah, pruritus, not nausea, vomiting. Opioid-induced pruritus. What is the drug of choice? It is actually ondansetron, 5-HT3 antagonist. Okay, it is ondansetron is considered as a drug of choice, but if, of course you can give antihistamines like cetirizine and other the drugs for pruritus, but ondansetron is generally considered as a drug of choice for opioid-induced pruritus. Okay. Any other adverse effects you want to discuss? Now we'll go to then toxicity otherwise. So these are the common adverse effects that we usually see. Now coming to toxicity. So what are the clinical features or symptoms of toxicity?
Myoclonus.
Myoclonus. Okay. Next. Other.
Respiratory depression,
Respiratory depression. Okay. But commonest, what will you notice? We just discussed that. What will be? Yes.
Sedation.
Sedation, drowsiness, excessive drowsiness, sedation, myoclonus, then respiratory depression, then one more. Delirium. Okay. So how will you manage sedation? We already told. We'll skip the dose till the patient is awake and then restart on a smaller dose. Okay. Second thing is, how will you manage delirium?
Haloperidol infusion.
Depending on where the patient is. If the patient is at house, you give haloperidol tablet, or if the patient is in your hospital, you can give IV also. But do you reduce the dose or do you just give haloperidol?
reduce the dose,
That depends on the patient's pain status. That is, if the patient's pain is in a stable pain, you think that you can reduce the dose without affecting the pain, then you can reduce the dose and add haloperidol. But if the patient is having mild delirium, but the pain is you think that the pain will go up if you reduce the dose, then you can just add haloperidol and see. Okay, that depends on the pain status, whether you have to reduce the dose or just add haloperidol. Okay. And about myoclonus, obviously you have to reduce the dose. Then my question is respiratory depression. When will you suspect the patient is having respiratory depression? Of course, the patient will be sedated. In our practice, I always tell my students, or whenever I get to, especially when I'm teaching people who are not practicing palliative care, like internal medicine residents or someone, actually these people, they are very because they are not using morphine, they are scared of morphine. That morphine or fentanyl means respiratory depression. So in that case, I always tell them, respiratory depression will not come first. You look for sedation. The patient, the first warning sign will be sedation. That is, if I tell that the moment that the patient sleep after the morphine dose, that they will call us, ma'am, the patient is sedated. That is when I tell them, you look for that inability to maintain a wakeful state or talking in a confused manner. If that is there, skip the dose and then reduce the dose, the patient will not develop respiratory depression. So the first thing to come will be sedation. So you have to look for that. Okay. Second is, how will you manage? How will you suspect respiratory depression? What will you see in the patient other than sedation?
Decrease of SpO2 status below
Okay.
80.
Okay, SpO2, but you are seeing the patient in the house. You don't have an SpO2 machine with you, probe with you. What will you see?
decrease in respiratory rate,
Correct, respiratory rate.
hypo,
If it is less than 8 to 9 per minute, that is the first thing to come. And then because then the SpO2 will come down, sedation, the decrease in respiratory rate, and SpO2 less than 85, all these are and pinpoint pupils. So all these suggest that the patient has gone in for opioid toxicity and respiratory depression. In that case, you have to go for which drug for respiratory depression?
Methadone.
No, respiratory depression.
Naloxone.
Naloxone, right. Okay. So due to time limitation, I'll not go into the naloxone details. We'll go to the then other adverse effects like addiction, dependence, tolerance, hyperalgesia, pseudo addiction. Do you have any doubts in these things? Because your patients will ask. The commonest question that I hear, because I these days deal mostly with non-cancer patients also, or mostly non-cancer patients. So sometimes we have to start opioids. So the question will be this. The first question will be this, because they will Google it up and they will ask you this question. After respiratory depression, this was the commonest question asked. So your patients can also, will also ask you, is there any chance of dependence addiction with morphine? What will be your answer? Cancer patients.
We have to take a history of the patient about substance abuse. After that, we can tell the patient or patient party about the addiction. In the case of, in many cases, that addiction is less commonly.
Yes, yes. Because in cancer patients, it is less commonly seen. If you give to non-cancer patients where you give for a long period of time, then the chances of addiction is more. And what about dependence? Is there a difference between dependence and addiction?
Yes, ma'am.
What is the difference?
In addiction, it will, if the patient will behave like without that dose, the patient will patient cannot do the necessary things in household, and the relationship between the patient and the patient's family will go down.
Okay.
And it causes anxiety, it causes pain abdomen, it causes mm,
so addiction is basically a primary, neurobiological problem. So there will be craving for the drug, and it is actually continuing to use the drug despite knowing that it will cause harm. So there will be craving and increased dose requirements. Whereas dependence is something that happens when you try to reduce the dose of the medicine, or when you withdraw morphine. That is when the dependence symptoms will come. The withdrawal symptoms will come, because dependence is something that happens, is a physiological thing that happens when the opioid concentration at the receptor level, when it decreases, this happens. So there is a difference when the patient will develop the symptoms of dependence and when the patient will develop the symptoms of addiction. Dependence, the withdrawal symptoms will happen when you try to reduce the dose or stop morphine. And tolerance and hyperalgesia. And what is pseudo addiction? Tolerance and hyperalgesia we see when you increase, the morphine is used for a prolonged period, the patient will require higher doses of morphine. That is tolerance. And hyperalgesia is often seen in other situations. I'll come to that later. Not in cancer patients. I don't think we commonly see hyperalgesia. So what is pseudo addiction?
Patient demands more drug when the pain is uncontrollable.
Yes,
and
correct.
we think that patient is.
Yes, very good. So that means the patient's pain is not controlled on your current regimen. And so the patient will have a tendency to ask for the more dose of the drug, because it is not controlled on the current regimen. So you think that it is addiction, that is pseudo addiction. So the point to be taken here is, whenever the patient says that my pain relief is not adequate in this dose, don't think that as a symptom of addiction, a sign of addiction or dependence. You have to do a comprehensive pain assessment. Maybe the disease has progressed, or maybe some new metastatic deposits have happened or something. So the pain is now more. That is why the patient is craving for an increased dose. Yeah, as somebody correctly told, you have to look for disease progression and then increase the dose accordingly. Okay. Any doubts? I think we have completed the discussion on morphine. Any doubts regarding morphine? In starting morphine, titrating, stopping, anything?
How will we titrate when we stop the drug? How will we titrate? Reduce the dose and stop?
Yes, 30%. You can usually we reduce by 30% every 2 to 3 days and then stop.
Should we
Madam,
give
also
gaps
any
in between
monoclonal?
so that tolerance issue is addressed? Should we give gaps in between?
Gaps meaning, ma'am?
Can we give NSAIDs in between so that tolerance doesn't develop?
NSAIDs in between means while the patient is on morphine itself, we are giving NSAIDs. That's what you're telling.
Yes. Can we stop completely morphine in between and give in between periods of NSAIDs only so that tolerance can
No,
be
ma'am, I
handled?
think that is not a good practice in cancer pain. In chronic non-cancer pain, we can do that. But in cancer pain, because we have to titrate morphine according to the disease progression and the patient's pain relief. And of course, you can use paracetamol as an adjuvant or any other adjuvants. That's what I'm coming to in the next session. You can use adjuvants so as to decrease the total dose of morphine. There is a conflict or there is a debate going on whether adding paracetamol actually decreases morphine's requirement or not. But in our
Okay,
Media's
is
practice,
tapentadol a good option?
I basically prefer not to combine opioids together. When the patient is on morphine, I will give as an opioid only morphine and add paracetamol as an adjuvant. Okay. And paracetamol.
What is the difference, ma'am, between tapentadol and tramadol?
Tapentadol is better tolerated and it has got better GI tolerated is a GI profile is better. Gastrointestinal nausea, vomiting. The GI profile is better, and also it has got a better role in neuropathic pain.
Okay, ma'am. Thank you.
Okay, so regarding
about cross tolerance, please say something.
Cross tolerance. Yeah, we'll come to opioid rotation. So
one more question about CR preparations, ma'am. Controlled release preparation.
Yeah, we are coming to that. We'll come to that in the second case. So right now, any doubts regarding starting morphine, titrating up, you can ask. We'll come to morphine, the sustained release and other fentanyl and cross in the second thing. Okay, now my just one question here in the last part of this case one. Suppose the patient's pain is controlled with 15 milligram morphine for the last 2 months. It is well controlled, but patient has reported with a new symptom, tingling numbness in the left leg along the posterolateral aspect till his big toe. Duration for 2 weeks, and the pain score is 4 to 5 per 10. So 15 milligram morphine, otherwise it was well controlled. This upper abdominal pain, this is a new pain. See a pancreas patient, this is a new pain. So tingling numbness in the left leg. What will you do? Do you increase the dose of morphine?
Again, assess for the patient assessment for pain.
Yes, that is, you are
We
telling
can give gabapentin, pregabalin.
Yeah, so you are telling that you will evaluate why the patient is having neuropathic pain in his left leg. Most probably, this is a radiculopathy, left leg along the posterolateral aspect. So this is a radiculopathy. So mostly patient will be having a spine met that is compressing on the left L5 root. Okay, that is why he's maybe. So and his pain is not very severe. It is like 4 to 5 in the moderate. So is there a role in increasing morphine?
Morphine is in good doses due to the pain. Due to it is not. It's the VAS score is 4/10. For the tingling and the numbness, we can prescribe him only 300 ODHs gabapentin or 75 pregabalin.
Yes, correct. The point taken. I think many of you have responded correctly. If this is a neuropathic pain, so just on hearing pain, don't go up the dose on morphine. Assess the pain, because I have seen this happening with many junior palliative care physicians. Just when the patient says my pain is not controlled, they will go upon the morphine dose. So that is an incorrect approach. If it is a neuropathic pain, the morphine's action on neuropathic pain is very less. Okay, so rather than increasing the morphine dose, or other than increasing the morphine dose, you can add a pregabalin, gabapentin, or a neuropathic pain adjuvant. Okay, so that is correct. Okay, actually I'm pressing my enter button, but the next this is not coming. Let's see. Yeah, so possible cause we have already told, management we have already told. Now, so you have optimized the neuropathic pain medications, and the pain was initially well controlled by optimizing the anti-neuropathic medications and on palliative radiation, because pain meds was the cause. But 3 months later, even though you have optimized, titrated the anti-neuropathic, the patient says that my upper abdominal pain is well controlled on morphine, but I am having severe neuropathic pain in my left leg. Now, how will you proceed?
We can add amitriptyline 25 mg
No,
half
already
OD.
optimized. Already it is, he's getting a very high dose of, that is why I have written, already the antineuropathics have been optimized.
We can go for L5 transforaminal block.
Yeah, that is good. But my question here,
Steroids, can we add steroids?
my question here was actually because we are restricting our talk to opioids, so I will not go for interventions here. My question here is opioid rotation. Which opioid you will rotate? The patient is coming from a poor
Methadone.
socioeconomic status. Yeah. The answer is methadone, because the patient is having a severe neuropathic pain. We have to rotate. We can rotate to a opioid which has got good action in the neuropathic pain as well. Okay, so now this is to open up the discussion on methadone. So now you can start asking your doubts or on how to start methadone for how to start methadone, how will you titrate methadone? First of all, what is the difference between methadone and morphine? One, we said it is neuropathic pain, correct? And two other actions. Or why methadone is different? Which receptors the methadone acts?
NMDA antagonism.
NMDA antagonism, and also it has got action on the serotonin noradrenaline reuptake inhibition, right? So it has got action. It has got some action on neuropathic pain, and secondly, it has got action on desensitization. See, in chronic pain or cancer pain, when pain is uncontrolled or pain is happening over a long period of time, there will be some amount of sensitization, peripheral and central sensitization. And this central sensitization is mediated by NMDA antagonist. So this methadone can decrease the sensitization. And one more action, it can prevent and reverse tolerance. We were talking about tolerance when you are giving morphine for a long period of time. So this can reduce the tolerance also. So because we are, I think, running short of time. Sunil sir, how much about methadone you need to tell now?
I think we can take another 10, 15 minutes.
For methadone or total for other
Total.
cases? Because we have the case discussion also pending. So how much
We can go till 7:10 p.m. and then we'll take the case discussion.
Okay. So methadone, if you are starting for an opioid naive patient, how will you start methadone? What is the starting dose of methadone?
In
Suppose
this patient is taking 90 mg morphine.
Correct.
So we can start methadone like 10 in this case 10 mg oral morphine equals to 1 mg oral methadone. So 9 mg oral methadone we can give, but we have only 5 mg methadone tablets. So 2 tablets, 1 tablet BD, 10 a.m., 10 p.m.
Okay, so if the patient is already on morphine, we can calculate the equivalent dose of methadone. and divide it as 2 or 3 divided doses, usually as TDS. And what is the problem with suppose we are starting on an opioid naive patient, okay, then what will be the starting dose? Initial for methadone, it is like start low and go slow. So what will be the starting dose of methadone if it is an opioid naive patient? So 2.5 milligram, somebody have written correctly, 2.5 milligram as BD or TDS will usually 2.5 milligram BD. That is how we start the methadone. So what are the what is the disadvantage of methadone? When we are starting and titrating up methadone, when you compare methadone to morphine, what is the disadvantage? What are the disadvantages?
QT prolongation, dosage depointers.
Pardon?
QT prolongation, ECG changes.
Yeah, you're talking about adverse effects. But I'm asking, when you are starting and titrating up, yes, somebody has written does not have a linear dose relationship. And what about the T half? What about the elimination T half of methadone?
Long T-half. Long T-half.
It is not only long, it is variable. Okay, they say it can vary from something like 5 hours to 30 hours or more. It has a long and variable T half. So what happens, there is a chance of an accidental overdose. Okay, and also another thing is what is the time taken for methadone to reach a stable plasma level? We told initially for morphine it is 24 to 36 hours. You review the patient every 24 hours or 36 hours and you titrate up. But what about for methadone? What is the time taken for a attaining stable plasma level?
5 to 7 days.
Yeah, it is 5 days. So you cannot, for a patient whose pain status is unstable and acute, severe pain with intermittent pain, breakthroughs and all, you cannot start on a methadone alone because it will take every 3 to 5 days. We have to review 5 days and then only you can titrate up. And it is just what a prolonged and variable T half. Okay, so so that is these are the disadvantages when you are titrating up methadone, and of course the precautions that you have to take. That is what she has told. It can produce prolonged QT interval. Methadone has got a lot of drug interactions. It is metabolized by the cytochrome CYP3A4 and 2B6. These two enzymes. So these two enzymes inducers inhibitors. So you have to, if you are prescribing methadone, you have to paste that chart, the drug interactions in front of you in your OPD. And every time you are prescribing more methadone, you have to see for drug interactions. Okay. And so what anything else in methadone? Any other doubts? Because we are running short of time. I want to discuss regarding sustained release preparations, fentanyl patch, and a little bit about other opioids. So anything else in methadone? I don't know how many of you have access to methadone. And so any other doubts regarding methadone? Even I am not using methadone because in my hospital where I am working, we don't have methadone as of now. We have applied for procuring methadone. So my experience is also less with methadone. But any other doubts, I think Sunil sir and Sridevi can answer. So you can ask.
When there is inadequate pain control, how will we increase the dose from 2.5 BD?
We review the patient every 5 days, as she said, somebody said 5 to 7 days, we review the patient, and we can increase by 2.5 to 5 milligram increments. Anything to add, Sunil sir? Regarding
So,
methadone?
yeah, regarding the increments, you are right. If a patient is taking less than 30 milligram of methadone per day, then the dictum is you can increase 5 milligram. Okay, then wait for another 5 to 7 days. But if the patient is taking more than 30 milligrams, you can increase by 10 milligram and wait for another 5 to 7 days. And if the patient is elderly or if the patient has liver failure, then you have to actually wait for 10 to 14 days before you increase the dose of methadone.
Thank you, sir.
And whatever be the dose of morphine, sometimes some patients might be on hundreds of. Suppose it is 1000 milligram per day. If you look at the dose, then the conversion factor would be 20:1. So that would come to 50 milligram of methadone. But you should never start patient on 50 milligram of methadone on the first day. Rather, whatever be the dose, you should never start the patient more than 30 to 40 milligram per day. So there are patients who are taking thousands of milligrams of morphine, and sometimes if you have methadone, probably these patients are taking higher doses of morphine because of tolerance. So if you convert that to methadone, then you need to give only small doses of methadone, not very big doses like 100 milligrams. There is no such instances. You need to start with 10 milligram TID. That's the maximum that you can start with. And another important thing is that if you start methadone, you should ask about reliable caregiver to administer methadone, because it is not like morphine. It has a long half-life and it can get accumulated. So if the dosage is not correct, then it is going to be a problem. It will get accumulated and it can produce more symptoms compared to morphine, and to relieve those toxic effects, it will take long time. And usually ECG and calcium, potassium, and magnesium is done because hypocalcemia, hypomagnesemia, and hypocalcemia all can increase the QT interval. So a few important points about methadone are it needs to be given in selected group of patients. So select this patient according to the indication. So some of the indications are complex neuropathic pain, opioid rotation, if the patient has opioid-induced toxicities, patients who has pain, but at the same time they have CKD, so a chronic kidney disease. So methadone is supposed to be eliminated mainly through bowel and the minor part through kidney. So methadone can be given safely in patients who has chronic kidney disease. And if the patient is allergic to other opioids, some patients may be allergic, truly allergic to other groups of opioids, then methadone is a choice. And pain resistant to other opioids. Suppose you have given fentanyl, morphine, buprenorphine, tramadol, tapentadol, still patient is not having it, then methadone is a choice. So you need to titrate the morphine, methadone only in 5 to 7 days. Don't increase the dose of methadone before that. And there are many drugs which can cause a lot of drug interactions with methadone, and those all drugs are which we use commonly in palliative care, like fluconazole, escitalopram, benzodiazepines, macrolide antibiotics, fluoroquinolones. All these have high drug interactions. So you should be very careful, and probably you have to have a very simple drug regime when the patient is on methadone. Okay, yeah, that's
Okay. So I think any other doubts on methadone you can put in the chat box. Thank you, sir. So next we'll go to the second case. So here we have a 54-year-old housewife who is a known case of CA breast with an ulcerated lesion on her right breast. So she's undergoing chemo and the pain is well controlled on 10 milligram morphine 4th hourly. But the problem is she has her daughter as the only caregiver. She goes for work and this patient has a cancer cachexia. She has tiredness. So she often misses the tablets. Okay. Because of that, she is having inadequate pain relief. So in that, otherwise the pain pattern is a continuous pain, nociceptive kind of pain, not much of an incidental pain or breakthrough pains. It is a continuous stable pain. But the only thing is that because she doesn't have a caregiver, she misses to take the tablets, or we can say poor compliance. So in that case, what are the options you have? What is the next step?
Extended release morphine.
Okay, so the first option is an extended release morphine. So our patient is on 10 milligram 4th hourly. So what will be the dose of sustained release preparation?
30 milligram BD.
Correct, 30 milligram BD. So what are the indications for starting this sustained release preparation? One is poor oral compliance. Then other indications, any other indication? See if the patient, pardon?
For managing continuous pain.
Yes, yes, stable pain, continuous pain without much breakthrough, without much incidental pain. In that case, you can give this sustained release preparation. And poor oral complaints. Any other indication? Suppose the patient is having dysphagia, painful swallowing. You don't have access to morphine oral solution. You can give us BD because you can avoid the discomfort of having to taking the morphine again and again. So that is another situation. Okay. So these are some of the situations where you can go for a sustained release preparation. Suppose you don't have access to sustained release preparation. This patient is having poor oral compliance with morphine. Otherwise, it's stable pain, continuous stable pain, but the poor oral compliance is there, and SR tablet is not available, or the patient has swallowing difficulty. Another option other than SR tablet, what is the next option?
Subcutaneous
Pardon?
Fentanyl patch.
Correct. So, I want to open up the discussion on the fentanyl patch. So, indications for starting fentanyl patch. We already told poor oral compliance, difficulty to swallow. Any other indication?
Why can't subcutaneous morphine be given? Why can't subcutaneous?
We are talking about a home-based care. If the patient is admitted, definitely. But that is again, how long you will give subcutaneous morphine? You will have to discharge the patient, right? Now, so one thing I forgot is while you are giving the SR tablet, you have to give immediate release morphine for PRN use. Okay, so what will be the dose of this immediate release preparation?
10 milligram.
Yeah, because this patient's total dose is 60 milligram. You divide that by 6. Whatever is the total daily requirement, you divide that by 6. That will be the dose of the immediate release, PRN dose. So you always have to give the patient this PRN, immediate release preparation for PRN use. Okay. Now, starting fentanyl patch, one we told is the poor oral compliance. Second is dysphagia, stable continuous pain. Another indication, seen liver failure or renal failure, there is less chance for accumulation of fentanyl patch. And if you don't have methadone, then that is also one indication. And another indication you already told, cross tolerance, or when you want to do an opioid rotation, that is one indication for starting a fentanyl patch. You have already gone up to maybe 50 milligram morphine 4th hourly. The patient is not having adequate relief, so that are signs of tolerance is there. Then you are thinking about opioid rotation, then you can go for fentanyl patch. But when you are rotating the opioid, how much will be so before that, how will you start the fentanyl patch? What is the dose? How will you convert? For not on an opioid tolerant patient, the patient is now the current patient, the 10 milligram morphine, 4th hourly. Total daily requirement is 60 milligram morphine. So what will be the dose of fentanyl patch?
60 mg morphine, equivalent dose is 25 microgram per hour of fentanyl.
Okay, that's correct. Around 50 to 60 milligram of oral morphine is equivalent to 25 microgram per hour of fentanyl patch. So that is how we convert usually. But suppose the patient is already on a high dose of morphine, you are suspecting tolerance, you want to rotate. Do you go with this conversion?
Decrease by 50%.
Yeah, that's what about cross tolerance. When you are suspecting tolerance and when you are converting into another opioid, you can start with a 50% dose and titrate up according to the dose, because if you start with this conversion, the patient may develop toxicity, because with the new opioid, the patient may not be requiring that much of an opioid, because with the other opioid, the tolerance has already set in. So go with 50% dose. Now the advantages versus disadvantages of fentanyl patch. I'll take another 3 minutes. So just the advantages versus disadvantage of fentanyl patch.
Onset of action.
Pardon?
Onset of action occurs 6 to 8 hours.
Yes, very good. So for the patch, always the onset takes some time. It almost 12 hours for the peak action to come in. And similarly, when you remove the patch also, the fentanyl has formed a reservoir in your dermis, okay, in the skin, below the skin. So even if the patient develop a toxicity and you remove the patch, then also the drug will be continue to act for another 12 hours. So titration is difficult. The onset of action is delayed. Titrating is difficult. With morphine, you can titrate continuously, but here the titration is difficult. Even if you remove, the drug will continue to act, and it is expensive. Another disadvantage is it is expensive. And because titration is difficult, similar to SR tablet starting, only for a stable patient, stable pain patient, you can start fentanyl patch. If the patient is having recurrent breakthroughs, intermittent pain, then it is not advisable to rotate to fentanyl patch. Anything else with regard to fentanyl patch? What is the advantage? We already told the advantage, no? Tolerance, and patient doesn't have to take. So advantages, I think, already covered. Disadvantages, I told it's expensive also compared to morphine and methadone. So that's it. So any other doubts we'll clear in the towards the last. So last one question, this I will, in just short, I will say, this is a non-cancer pain patient, retired police officer, 65-year-old, with a very good socioeconomic status. So diabetes mellitus, severe burning pain in bilateral leg and feet. I'm sure you know the diagnosis, it's diabetic neuropathy. The patient has been started on pregabalin 75 milligram and amitriptyline 10 milligram, already on that, and he's taking a high dose of tramadol, 100 milligram TDS, but still he's having severe pain, especially at night. And the diagnosis is neuropathy, I already told. So what is the next step? Tramadol already on a high dose. What is the next step in management? It's a non-cancer pain also. The patient is from a good socioeconomic status. You don't have access to methadone.
We can go for interventional pain management.
Yes. But I'm again telling, this class is regarding opioids, so we'll stick on to opioids. Which opioid you'll use? That's my question. Which opioid has got, other than tramadol and methadone, which other opioid has got good? Will you start morphine or will go for any other opioid? Will you start morphine for this patient? How many of you will start morphine for this patient for diabetic neuropathy? I will not start. Maybe I will think thrice or 4 times or 5 times before starting morphine. But this patient is from a good socioeconomic status. And what is one another? I don't have access to methadone.
Buprenorphine patch.
Pardon?
Buprenorphine patch.
Correct. Very good. So methadone is one option, but again for non-cancer pain, and the patient is from a good socioeconomic status, you can go for buprenorphine patch. It has got very good action in neuropathic pain, and buprenorphine patch is expensive. 10 microgram per hour costs around 1,200 rupees. Around 1,200 rupees. One patch acts for 72 hours, and it is expensive, and it takes time for onset of action, almost 24 hours. Okay, so these two are the disadvantages of buprenorphine. But the advantage is it is good in neuropathic pain. It doesn't have dependence addiction potential when compared to morphine or fentanyl. And the third is dizziness, sedation, drowsiness is relatively less with buprenorphine. All these side effects of morphine, because it is a partial agonist antagonist, so the side effect profile is better. And I constantly use in even dialysis patients, CKD dialysis patient, peripheral vascular disease, and respiratory comorbidities. All these patients I'm using buprenorphine with good result, but I don't use for cancer patients and nociceptive pain. This is for, I have seen good results with neuropathic pain. Okay, why not for cancer pain? Because that's severe pain. It is difficult to titrate with buprenorphine, and it is expensive. And why in this diabetic neuropathy I will go for buprenorphine patches? I need time for optimizing the anti-neuropathic agents. You can see he's on a small dose of pregabalin and amitriptyline. So you have a lot of options there. You can optimize, but that will take the time for action. The pain is already 8 to 9 out of 10. The patient is having severe pain, so you don't have that much of a time. The optimizing the anti-neuropathics will go on for the next 2 to 3 weeks. So for that, I will go for a buprenorphine patch. Okay, that is my choice if that is available and the patient can afford. Or you can go for methadone also as a less expensive option. So I think I have completed all the points. Anything regarding buprenorphine patch, fentanyl patch, SR preparation, or morphine, we can take at the last also. Any other questions? I think we'll go for to the case discussion now. Okay, sir?
Yeah.
I will
Srinath, you
stop
can
sharing my.
take
I'll stop
one
sharing my
patient
screen.
story.
Okay.
Yeah.
Sunil sir, can you move on to the case presentation of Dr. Anju Anna?
Yes, yes. We'll take only one patient story.
Dr. Anju, ma'am.
The screen will be moved from there, no?
Yes, ma'am. Yes.
Okay. This is regarding a 76-year-old male who has been diagnosed with advanced squamous cell carcinoma of the right buccal mucosa. Presenting complaints were pain over the right cheek and the right side of the neck. The patient had difficulty in swallowing. He also had poor oral intake. There is some ulcerated right-sided swellings on his neck, and also he has recent history of weight loss. History of his present illnesses. He is a 76-year-old man who was evaluated for pain while chewing, along with neck swellings of 2 months duration. The patient underwent tooth extraction of the 2 upper molar tooths 2 months back for the pain without any relief. Now the pain has increased and it is constantly present over the right cheek and neck region. Pain increases on jaw movements and chewing. Patient is not able to chew or swallow food due to the pain. Initially, the pain got relieved with some tablets, but now it is not relieved by any of them. Recently, the neck knots increased in size and it's ulcerated, and a blood-tinged discharge is oozing out from it. There is a foul smell around the area. On examination, he is having an echo performance status of 2, no trismus or ankyloglossia. Swelling is there with tenderness at the upper gingiva on the right side above the extracted molar tooth with ulceration. Multiple hard cervical nodes in the right level 1B, 2, 3, 4 with ulceration, blood-tinged discharge and foul smell. Chest is clear, upper abdomen soft, no organomegaly. Significant investigations. Routine blood investigation showed anemia along with hypercalcemia of malignancy. There is leukocytosis suggestive of infection, hypoalbuminemia. His dental evaluation showed multiple dental caries, tobacco staining present, and advised scaling. Biopsy from the node was suggestive of squamous cell carcinoma. His PET-CT showed a metastatic disease with ulcerative lesion from the right gingival buccal sulcus extending into the maxillary antrum. multiple matted ulcerated right cervical nodes, lytic lesion in the C6 vertebra. He was seen by a surgical oncologist and a radiation oncologist, and they have opined that the primary surgery and radiation treatment is not possible. The case was discussed in the tumor board. The patient was planned for palliative chemotherapy. The psychosocial aspects: he is a manual laborer, poor socioeconomic status. He has studied up to the 4th standard only, but because he is an ECHS beneficiary, his chemo drugs and his treatment things has been sold a little. 2 daughters are there, but they are married and they are staying away. He and his wife are staying together. There is poor social support. The smoking addiction is there. He was continuing smoking till the diagnosis. There is pain, there is ulceration, there is discharge which require daily dressing. There is superadded infection over that which causes foul smell. There is difficulty in swallowing and therefore he has poor oral intake. The nutritional problems are also associated with the poor intake like anemia, hypoalbuminemia. And also finally the cause of all of this, that is the advanced stage 4 disease, and also a lytic lesion in the C6 which if it breaks and if a fracture happens, chance of a quadriparesis. So he is a 76-year-old elderly frail smoker with stage 4 carcinoma of the buccal mucosa, multiple ulcerated cervical nodes with pain over the cheeks, adenophagia, ulcerated tender nodes with continuous discharge. So the discussion points for the class: do we need to provide palliative treatment for this patient? What are the problems faced by this patient? And what all can be done for the pain management of this patient?
Okay, I think we will take only the last point for today's discussion. What all can be done for the pain management for this patient? So, can any of you comment on what would you do if this patient comes to you for pain management?
The patient is unable to swallow due to the right-sided squamous cell carcinoma stage 4 with ulceration. We can go for fentanyl patch for the reduction of the pain because he is unable to swallow the tablets.
Okay.
What is the problem in starting fentanyl patch this patient? Do you think had any disadvantage in this patient if you start on fentanyl patch? Because you can start, but the thing is, problem is, as much as I have understood, right now the patient is having uncontrolled pain. Pain is not severe pain. Patient is having severe pain, not controlled on other analgesics, maybe paracetamol, tramadol, and everything. So in that patient, if you start the fentanyl patch, it will take 12 hours for action, and you will not be able to titrate the patch. So if you start on fentanyl patch, what else will you do?
We have to prescribe rescue doses of morphine.
But patient is unable to swallow, no?
IV morphine.
Yes, actually, that is one option. You can admit a patient and give some, because the patient is not able to swallow. So you can admit the patient and give IV morphine as PRN while the patient's fentanyl patch takes its action and pain is stabilized on the patch. It is very difficult when you start on a directly on a patch. It is difficult to titrate and for the onset of action to come, then the plasma levels has to get stabilized. So any other first line option other than fentanyl patch, any other first line option? Suppose you have to send the patient home.
Dr. Ajmal says the rectal morphine.
Rectal morphine. Any other option? No, IV rectal, but what's the simplest option if you have access to it? And
liquid
if you have to,
morphine.
yes, liquid morphine, oral morphine solution is available. So liquid morphine is my first choice if I have access to it, because I can titrate. When I'm starting the opioid, I need to titrate. If I don't know on what amount of opioid he will get adequate pain relief. So I will not start on a patch. If I have access, I will start on an oral morphine solution. And once the pain is adequately controlled on oral morphine solution, if I want to change to a patch, if the patient can afford it, and because one patch costs 500 rupees and it lasts 72 hours, 3 days. So you can just calculate the cost needed over long time. Okay. So oral morphine solution is a better option than cost-effective option than fentanyl patch.
Or even you can powder the morphine tablet
Yes,
and
yes.
actually, if you powder the tablet, it is bitter. So you have to sweeten it with fruit juice or sugar, and it is also hydrophilic. It is water soluble. So you can administer to the patient if syrup is not available. Anybody else?
And since we were discussing about fentanyl patch, one point I have noted while during the case discussion is hypoalbuminemia. Isn't it, Dr. Anju? You talked about hypoalbuminemia, right?
Yes, ma'am.
So cachexic patient and hypoalbuminemia, any special consideration for fentanyl patch? They say that in cachexia and hypoalbuminemia, absorption of the fentanyl from the patch, it forms a reservoir in your dermis, and from there it is absorbed in the systemic circulation. So in cachexic patients and hypoalbuminemia, you will need a higher dose of fentanyl patch because this reservoir forming and absorption is less. So that is one consideration. You may actually, because in cachexic patient, we usually try to reduce the dose. We try to start with a smaller dose, but in fentanyl patch, it may be the opposite. They may need a higher dose of patch. And you talked about hypercalcemia also, Dr. Anju. So is that a contraindication or a special consideration for starting any particular opioid?
Renal friendly opioids, because hypercalcemia can in turn lead to renal failure.
Yes, and also Dr. Ajmal replied correctly, methadone. Because hypocalcemia, or any electrolyte disturbances that will, especially calcium disturbances, that will increase the chance of a QT prolongation. Okay, so suppose not for this patient, definitely we are not going to start methadone. Methadone is also available as an oral syrup. You know that, it's available as a solution. So methadone is a possibility for this patient, even though it is difficult to titrate and all. But while starting methadone, this hypercalcemia, you have to remember that. Anything else to be discussed here, sir?
Ma'am, IV morphine, we will start with 5 milligram and we will see for the rapid rescue like every 10 minutes to see, is it so?
Not 5 milligram. So you are talking about IV morphine trial, correct? Good that you pointed out that, because we have missed that. So IV morphine trial, because only if the patient, because while in India we do a lot of home care also. So I was mostly discussing around an OP based or a home care based protocol. So, but suppose a patient is coming to your hospital or your ER with severe pain, and even oral morphine will take some time for action, then we have to titrate. So all these takes some time. So how do you do the IV morphine trial? You start with 1.5 milligram, 1 to 1.5 milligram IV, and you titrate it every 10 minutes, 5 to 10 minutes. You look for the response and give increments of 1.5 milligram. And what is your endpoint? Till
Adequate pain relief.
or sedation, whichever comes earlier. Okay, at that point you have to stop and you see how much the patient responded to, how much amount of morphine the patient had taken. For example, the patient responded to 6 milligram of IV morphine. Then you convert that to oral morphine. So how will you convert that to oral morphine?
Into 318.
Yeah, almost like if it is
3:1.
yeah, 3:1. So that much amount of morphine ideally you have to give every 4th hourly, or you can go for a morphine infusion initially. But usually we don't do that. If you convert that to the oral morphine and give every 4th hourly. Okay, half to 1/3. Sometimes you can multiply by 2 and start also. Subcutaneous is actually for subcutaneous preparation you multiply by 3 and parenteral by 2. Isn't it like that, Sunil sir? It is half to 1/3, no, the conversion.
Yeah. Usually, if the patient is on 30 milligram of oral morphine, when you convert to IV, it will be 1/3. That is 10
Yes.
milligram IV. And to subcutaneous, it is 1/2. That is
1/2.
That is
Yes.
15 milligram. But these are not hard and fast rules. It may vary between half to 1/3. And another thing which I want to tell you is that suppose the patient is opioid naive. That means if the patient has not taken any opioids, and if the patient is coming with severe pain, and you are giving injectable morphine or IV morphine trial, then the dose of oral morphine that you have to start after IV trial is the same as oral morphine. So this has been proved or studied, and this has been published in Journal of Pain and Symptom Analysis. So that means when you are giving injectable morphine only for maybe within 1 hour, you might give maximum of 6 doses. And then you are converting it to oral. So then the ratio would be 1:1. But because you know that morphine will take about 24 to 36 hours to have the blood level stabilized. So that will not happen if you give IV morphine trial. But if the patient is on IV morphine for the past 24 hours, and then if you convert to oral route, then you have to multiply by 3 to get the oral route. But if patient is opioid naive and if you are giving opioid or IV morphine trial for the first time, then you have to convert oral like 1:1 ratio.
Yes, like Sir said, there is no hard and fast rule in that. Usually, depending on the patient's condition, the frailty, renal parameters, and the liver function, all depending on all that, you can convert to the appropriate morphine oral requirement, oral morphine dose. It need not, if you start on a 3 times dose for an opioid naive patient, he may develop the adverse effects, sedation, drowsiness, or toxicity. So it is better to individualize according to the patient's condition and the parameters, whether he is opioid naive or already on opioids, and depending on all that, we can individualize how much we have to. But the IV requirement will give you an idea of how much the patient will require, and then we can individualize accordingly.
Okay. So I think we will stop here. It's 7:35. And if you have any doubts, please write to us. Christina will be there, take up those questions, and or even you can post your question in the WhatsApp group, which we can take up. So thank you, Vineetha, for joining us today, even with even if you are some throat fever, but we are happy that you were able to make it up. And thank you everybody for joining us today. And I would request all of you to complete the modules before coming for the session. And please be more interactive, then only we will get more out